Welcome to the special edition of Healthcare Radius podcast on the occasion of World Cancer Day. Today we have Dr. Ishita Sen with us. She's the Director of Nuclear Medicine at Fortis Memorial Research Institute, Gurgaon. She has over 20 years of experience and has worked in various hospitals across Delhi NCR. She takes a special interest in nuclear oncology and radionuclide therapy. Welcome, Dr. Sen.
Thank you.
My first question is nuclear medicine has come a long way from the rectilinear scanner in the 1940s to the modern day advanced digital PET and CT or digital PET MRI scanners. What have been the most significant changes that you have seen in the field of nuclear medicines over the years in the areas of oncology, neurology, and cardiology?
Basically, if you divide the developments which have happened in nuclear medicine over the past couple of decades, you can divide it into two parts. One is the developments which have happened in the imaging technology, which is basically the scanners which have improved. And the other end, which is equally important, probably more so, is the developments which have happened in the molecules. So the molecules which we use for imaging, which we use for therapy, those are the ones which have developed over the years and have actually ushered in an age of theranostics. So I think we will come to theranostics later. But what has happened is that from a time when we were mapping very general processes, like say, for instance, we used to do bone scans. When I was a student, we used to do bone scans which looked at metastasis from various kinds of cancer, but the scan would look kind of similar. So while on a bone scan, you would be able to differentiate that, yes, this patient has skeletal metastasis or not, it would not give us any insights as to where these tumors are coming from. As compared to that, today we have scans which actually look at a particular molecular process or a kind of tumor. So you have a different kind of a scan for a prostate scan. You have a different kind of a scan for a breast scan. From a very generalized kind of a subject, we have come into precision, individualized, personalized medicine. And this has been possible not just with the molecules, but with also the advent of the new scanners or the hybrid imaging, which has happened. So from a time when we used to have just rectilinear scanners and gamma cameras, we moved on to having PET CT, SPECT CT, PET MR. So it's a hybrid modality which looks at not just function, but also with the function and structure, right? And then there were further improvements in the scanners, which ushered in very high precision imaging, which like things like time of flight. So that was something which really changed the entire paradigm of nuclear medicine imaging, especially PET imaging. So you started getting images which were extremely sharp, which could track the process in the body as it happened. So it was not just spatial resolution, but also temporal resolution. And that further has changed now with the advent of technologies like the digital PET CT. So digital PET CT, the hallmark of digital PET CT is that it has got a very high temporal resolution, which allows us to actually do dynamic PETs. So as the process is happening in the body, you can track it. So it's like you can follow a particular molecule right from the time that it has been injected into the vein to the time that it finds its target in the body. So all this has been possible with technologies such as time of flight, with digital PET. So these are the technologies which have really changed the way nuclear medicine has been performed in the last couple of decades.
So, though PET has been a valuable research tool for many decades, its real growth into clinical applications has occurred in the last decade or so. The recent advances in the imaging techniques have further widened the comprehensive and the convergent applications of PET in the clinical management of cancer. Could you brief us on PET CT based imaging techniques relevant in India and their clinical benefits?
So PET came into India somewhere around 2005, 2004, 2005, when the first scanners were installed first at Apollo Hyderabad, then subsequently at the Tata Memorial Hospital in Mumbai, in at All India Institute in Delhi and at the Gangaram Hospital in Delhi. So I was fortunate enough to be a part of this process because we started doing our PET. We were one of the. I was at that time at the Gangaram Hospital in New Delhi, and we were the Mahajan Imaging Center was amongst the first ones who started the PET scanner in the private sector, and it really changed the way oncology started being practiced in this country. So, what the way it changes is it tells us not just in the diagnosis and the staging of cancer, but more importantly, to look at the response of various. Chemotherapy. So that was what actually made this because earlier you would on it despite the fact not benefiting the patient or not, and this would cause not just physical toxicity to the patient but also financial toxicity because these were expensive drugs. To give you a way in which we could actually assess the response of particular chemotherapeutic regimes in the interim. So you give 2 cycles and you do a PET and you know whether it's working or not working. And based on those findings, they could tailor the chemotherapeutic regime. So a lot of changes which came in the treatment of cancers happened along with the advent of PET because that gave us a way in which we could tailor managements based on individualized response. So from a one size fits all, it's kind of moved on to a more personalized or individualized medicine. And then this was the time when we were primarily doing FDG PETs. FDG, which is basically a glucose PET, which is a more general kind of a PET, which is used in many cancers, not just a particular specific cancer. From there, we moved on to actually having particular targets which were specific to a different kind of a procedure, which may be specific for a specific kind of treatment which a patient is having. For example, you have something called as a Dotanox scan. Dotanox scans are used in patients of neuroendocrine tumors, which look at the somatostatin receptor expression. And these scans actually tell you whether this patient has got this particular receptor or not, and whether he's going to respond to a particular kind of treatment or not. So all this ushered in a whole lot of individualization and personalization to the cancer treatment. So this was personalization based on molecular imaging, based on the receptor imaging, based on response to a particular, chemotherapeutic or immunotherapeutic regime.
My next question was on the medico-economic usefulness of the PET or CT. You
Yeah.
partially answered it.
Yeah, I partially answered it. Also, to look at it, the way PET CT is done in a resource constrained country like ours is that we try to pack in as much information in a one particular investigation as compared to much of the Western world where things are governed by a different kind of economics. It's governed by the insurance payers and the kind of protocols which they have. Here in India, if a person has a single PET CT scan, he gets the benefit of not just a PET scan, but he gets the benefit of a high resolution, contrast enhanced CT of the head, of the neck, of the chest, of the abdomen, and of whatever region is involved. So that makes a lot of sense because in one shot, the patient is not just getting a whole body assessment of the extent of disease, but also getting an assessment of the loco-regional disease. So the PET CT with the contrast enhanced diagnostic CT, which is done in India, is gives the not just the a holistic kind of a image, but also gives you the loco-regional so that the surgeon knows where to operate, surgeon knows whether he can operate or not, and if he has to operate, which are the planes which are clear. So it gives you a complete information. So I think this is one thing which where India led the global paradigm because we were the first ones who, because being a resource constrained setting, because we could not afford, our patients could not afford a different, a CT, having a CT separately and having a PET separately and then coming to the hospital. So it was loss of man days, loss of revenue. Patients were spending more, having multiple procedures. Some patient would require sedation, so they would need multiple sedation. So all this changed because we started doing everything in one. And slowly the world has woken up to this. And across the world now, diagnostic, earlier when I was when we started doing PET scanners in 2005, the Western literature would say that it was all non-diagnostic CTs which were done along with the PET scans. But now today, everywhere you look at it, it is diagnostic, high resolution CTs, which are then married to the PET, or they're high resolution MRs, which are married to the PET, and you get a complete information. So I think sometimes necessity breeds innovation, and this is one area where we actually managed to do it. So in terms of economics, it reduced the amount of money which a patient was spending for getting the diagnosis as well as the staging of a particular cancer. And then because we could do response evaluation, we could, patients were not wasting money, or the companies or the state for that matter was not wasting money giving therapies which were not doing good to the patient. So you could tailor the management regime. You could change the chemotherapeutic drugs. So you could change the chemotherapeutic drugs based on the receptors which were present. So all this has actually, over a period of time, is not just reducing the cost of treatment, but also optimizing therapy to a large extent, both in terms of the finances as well as in terms of the better patient outcomes.
So, in nuclear medicine, the Theranostics approach is an established tool for specific molecular targeting both for diagnostics and therapy. Thanks to the ongoing research and development of newer radiopharmaceuticals and the diagnostic techniques, the therapeutic use of nuclear medicine could be continually increasing. Could you brief us on the therapy or treatment aspects of nuclear medicine?
Yeah. So theranostics comes from two words. One is therapy and one is diagnostics. So the same molecule, which is used for, it's actually see and treat. So that the diagnostics sees and the therapeutics treat. So you see a particular process, or you see a particular kind of tumor, or you see a particular kind of receptor, and you treat the patient by the same receptor or process or tumor. So, for instance, if you have a patient who has got a prostate cancer, all right, so you have an agent called gallium PSMA, which is used for actually doing a PET scan or doing a diagnostic scan for this patient to see the all the sites of metastatic disease. And the same PSMA molecule is then labeled with a therapeutic molecule, which is called lutetium or actinium, which is then injected into the patient. Now, this therapeutic molecule actually seeks out all the receptors, all the sites of tumor which are expressing the PSMA receptor, and it gets trapped at those sites, it gets accumulated at those sites, then it emits local radiation at those sites, and it treats the tumor. So this theranostics, while it is not a concept which is only used in nuclear medicine, it is used in various other modalities in laboratory medicine, in immunotherapy or chemotherapy drugs, which are based on these the theranostics in the lab medicine. Nuclear medicine is actually the most potent tool in terms of the theranostics. So whether it is neuroendocrine tumors, whether it is breast cancer, whether it is prostate cancer, whether it is certain types of gliomas, whether it is meningiomas. So theranostics actually allows you to both see the disease by a diagnostic tool and treat the disease using a therapeutic tool in the same with the same, which is targeting the same receptors. This is basically the most elegant use of personalized or individualized medicine.
How do you see the training of residents and technologists in our nuclear medicine training programs?
We have about more than DNB and MD residents who come out of nuclear medicine every year. And I think every year the number of postgraduates in nuclear medicine is increasing, but there is still a huge gap in the number of doctors required, the number of trained doctors required, vis-a-vis the number of centers which are coming up. So there is almost, I would say, at least a 25 to 30% gap in the number of postgraduates who are available vis-a-vis the number of centers. And this is especially true when you go outside the bigger cities. So when you talk about the level 2 or level 3 cities, there is a huge dearth of manpower there. And also, now nuclear medicine is slowly becoming a vast field. And so while you need a basic training in nuclear medicine, it's also the time when more specialization is happening in nuclear medicine. For instance, the All India Institute has started a DM course in nuclear medicine therapy. So again, while we need to increase the number of postgraduate institutes, we also need to focus on developing the certain niche areas of nuclear medicine, whether it is diagnostics or therapy, and creating people who have the super specialization in these particular kind of things. So I think when you talk about the residency programs, we have one of the best residency programs in the world. So our students are, wherever they go in the world, they are they are usually at the top of the class, or they are usually getting accepted at very prestigious programs. But the problem is that we still need almost about 25 to 30% more postgraduates every year to sustain the number of we need to increase the number of postgraduates who are coming up every year.
What are the disruptive innovations in nuclear medicine, and how do you see the field of nuclear medicine evolving during the next decade?
I think the most disruptive innovation which has happened in nuclear medicine is the advent of hybrid imaging. So hybrid imaging means where the two technologies like CT and scintillation detector, or an MR and a scintillation detector, have been married into, or a gamma camera and a CT have been married to create scanners like the PET CT scanners or the PET MR scanners or the SPECT CT scanners. So this was the most disruptive innovation which happened, which changed the entire look and feel of nuclear medicine and brought it to the center of medical practice, as compared to the peripheries where it used to be in the say in the 60s or 70s, or even in the early 80s. So that was the major change which happened. The second change which happened was when there were newer advances in the precision of the imaging, which was brought in by things like time of flight or digital PET. So digital PET again is poised to be, we still don't know whether it's going to be a disruptive innovation, but it looks very encouraging because the quality of the images which are coming in are so far improved as compared to prior, that it is very likely that it's going to change the way the world starts viewing the nuclear medicine images. Also, the other disruptive innovation was the advent of these targeted molecules. So that changed the way nuclear medicine was, from the beginning. The scope and the extent of the usage of nuclear medicine increased exponentially when you started having these particular targeted molecules. So I think those were the two areas which were really disruptive innovations. So both in technology of imaging as well as in the molecules which were used for imaging.
You have been in this field for over 20 years. So tell us about your experience and how the field, technology, and equipment have evolved over a period during your time.
I've been in this field for more than 25 years, actually. I finished my post-graduation in 1998, which is, and in those days, there was the gamma camera and there was the rectilinear scanners. And that was about it. And we used to, in our textbooks, the chapters on PET scanners, we would just turn those pages over saying that we would never see a PET scanner in our lives. So what's the point of reading that? So from there, we came into a system where we are today, I think, at the forefront of the world in terms of both imaging as well as the therapeutics, right? So we have patients now coming all the way from the United States, from UK, from all over the world who come to India to get nuclear medicine therapy. So it has been a very, very exciting time the last 25 years because it has changed the whole way. We were, nuclear medicine used to be one of those paper basket subjects where people who would not get anything else would take up nuclear medicine. From there, today we have come to a point where nuclear medicine is one of the most coveted branches of medicine. When you talk about the postgraduate level, when you talk about the medical graduates, the choices which they make for doing post graduation, nuclear medicine is one of the most coveted branches. That was the kind of change that happened in my time. Also, the rate of change is, or the trajectory of growth has really become very steep, right? So every day, every month, every year, you have newer technologies. You have not just in diagnostics but in therapeutics also. So it's a very exciting time, and I think this is the time when nuclear medicine is actually poised for its next jump into the mainstream of medical practice.
The future of nuclear medicine and how we can increase the availability of nuclear medicine facilities in the rural areas of India.
So I think that is something which we really need to work on. And I think the government of India is already doing that. There is the first thing that we need to do is to become self sufficient in terms of the radiopharmaceuticals. Right. So right now, many of our radiopharmaceuticals, while the Bhabha Atomic Research Center and their radio pharmaceutical division, which is called BRIT, is doing a lot of things to develop these molecules in the country. Many of our molecules are imported from outside, and that is what is responsible for not just the high costs of the nuclear medicine procedures, but also the availability, because a small center in the remote part of the country may find it very difficult to actually, and these are time, there are time constraints, these are time sensitive kind of pharmaceuticals, so it's the logistics becomes that much more difficult. So number one, we have to become self sufficient in this country in terms of the radiopharmaceuticals, and I think the Department of Atomic Energy is now planning a reactor which would specifically cater to the radiopharmaceuticals, and that is planned, and hopefully in the next 4 to 5 years that reactor will be up and about and doing all the, giving us all the radiopharmaceuticals that we require for our medical practice. The second issue is the scanners. So many of these companies, whether it is GE, whether it is Siemens, whether it is they have started doing this Make in India. And so many of the scanners are now being made in India, and as a result, the cost of the scanners is coming down. So what used to be, say, a 10 crore machine, now you can get it for 5 or 6 crores, because it is being made in India and being made with local expertise, and hence the cost of the entire process. So again, that is making these scanners available and making it in a cost effective way, not just in the tier 1 or tier 2 cities, but also beyond. So today you have people coming from, there are PET scanners in Meerut, in the tier 2, tier 3 cities of Gujarat, of South India. So there's a lot of penetration of nuclear medicine, but of course we still need to do much, much more. We are just at the tip of the iceberg today. And even with the scanners, many of the advanced nuclear medicine scans are not available outside of the big tier 1, tier 2 cities. And that is something which has to change. Also, public private partnerships have to come up and develop, cost effective solutions for developing nuclear medicine across the country. So I think the government also realizes, and a lot of private entrepreneurs are also getting into this. So the future of nuclear medicine is definitely very bright. I think in the next decade, we have this this they said that the last decade belonged to the machines. The next decade is probably going to belong to the molecule, as well as to a lot of other innovations like artificial intelligence, which is coming up in in imaging to a large extent. So all these things are going to make not just the lives of patients better, but is also going to have much more penetration and availability of these technologies to the remote parts of the country.
Thank you, Dr. Sen, for giving us insights into the nuclear medicine area in India and about the imaging part.